So let's run through examination now of the foot and ankle. Firstly, we need to expose the patient, and shorts would be fine, ideally down to their underwear. And as they're getting undressed, just make a note of, are they moving comfortably? Do they have any walking aids? Have they got razors on their shoes? Shoes are very important, obviously, for foot and ankle pathology. Any obvious rheumatoid arthritis in their hands. So the first thing to do is inspection. So just face me, sir. So on inspection, it's obvious that his limbs are well aligned. He's got no obvious deformities of his knees. He appears to have good quality skin. I note he's got a small, presumably post-traumatic scab on his left ankle. His ankle appears to be in normal alignment. His forefoot is not excessively splayed. There's no bunions or obvious clawing. Slight curly deformities of both little toes. Okay, so can you turn to this side? Looking from the side. Again, he stands with good overall alignment. His knee is fully extended. His heel is flat on the floor. And there's no obvious scars around the lateral malleolus. And he doesn't have a bunionette. And facing away from me now, please. From behind. Once again, no obvious knee pathology. No wasting of his calf. He stands with a normal valgus alignment of his hind feet. And he doesn't have a positive too many toes sign, in that I can see the lateral 1.5 of his lesser toes. And face me now, sir. And just finally, we'll just double check on the medial side. There's no obvious scars. And he has a normal arch, which will comfortably admit one finger. Okay, good. Now, can I see you go for a walk, please? So, inspecting his gait, looking for symmetry of gait, normal stance and swing phase, normal heel strike and toe off. Specifically with the ankle, we're looking for a stiff ankle gait, an antalgic gait, a drop foot gait. So, a good screening test now is to see if the patient can stand on tiptoes. So, if you take them to the door and just put your hands against the door now. And can you now stand on tiptoes? And as we do that, and go down again, we'll see that his hind foot moves from slight valgus into slight varus. Stand on tiptoe, and his hind foot swings into varus. And then go down again. Okay, and now can you just do it on one leg at a time for us, please? And so you can perform a single toe raise on the left and the other side, and a single one on the right, suggesting that his tibialis posterior tendon is intact. Okay? So now we've got you on the couch, we'll examine, we'll re-inspect a bit more closely. The overall shape of the foot hasn't changed. Again, there's no obvious scars. Checking on the lateral side. Again, no scars to see. And on the medial side. Now we can focus really on the sole of the foot. He's got some dry, hard skin on the heel, a little bit over the fifth metatarsal head, and across the lesser metatarsal heads, but there's no obvious corns and callosities. Just checking between his toes, no signs of infection. Okay, so we'll now move on to palpation. Firstly, you have a quick feel of the ankles, the temperature. All feels normal. The focus now is on palpation for tenderness. We'll palpate the lateral malleolus along the lateral, the posterior border of the lateral malleolus, the calcaneofibular ligament, posterior talofibular ligament, and the anterior talofibular ligament, which is injured in a classic ankle sprain, and then the anterior syndesmosis. Across the front of his ankle joint, extensor tendons, intact and non-tender, tibialis anterior, non-tender. Coming around to the medial side, medial malleolus is non-tender, the deltoid ligament is non-tender, and then the tibialis posterior tendon and the tibial nerve are non-tender. The Achilles is non-tender and is not thickened and is non-tender, and his calcaneal tuberosity similarly is non-tender. Coming to his foot, any areas of obvious pathology we'll focus on and check for correctability of deformity or for tenderness. But in general, I think it's worth just palpating over the metatarsal heads. Check there's no obvious subluxation or tenderness. Feeling over the base of the fifth metatarsal for any tenderness, and over the origin of his plantar fascia. And again, he's non-tender there. Now we need to move on to movements. Now movements of the ankle can be quite difficult to assess because there are so many other joints around the ankle, and you've got to really try and isolate the ankle joint from those other joints. So what I would do is I would bend the knee gently, pop the leg over your thigh if necessary, and grasp the heel, and use your index finger as a goniometer or a pointer to indicate the angle. So we can dorsiflex his ankle, and my index finger indicates about 15 degrees of dorsiflexion, and flex the ankle, it's about 40 degrees of plantar flexion. So dorsiflexion and plantar flexion, and that's normal. Now I want to check for the subtalar joint. To do that, I need to palpate his talar head, grasp the heel, and then inversion and eversion. So inversion about 30 degrees, eversion of 15 degrees. So that's his subtalar joint. And then the midfoot joints, you grasp the heel and supinate the forefoot and pronate the forefoot. And it's difficult to give a range to that, but you can certainly get a sense of normality and a sense of whether it's painful. Movement of the toes, I think it was a quick screening test. You should just do a global movement of the toes. So can you bend your toes backwards and then down, curl them up, and that looks fine. Clearly, if you've got some isolated pathology, say a bunion, then you can focus specifically on the range of movements of the individual joint in question. Similarly, if you've got any deformities of the toes, such as a claw toe, can you straighten that out? Is that correctable? Now we just need to go on and test the neurovascular function. So feeling for a posterior tibial pulse, dorsalis pedis, and then we check now for sensation over the dorsum of the foot. That's the peroneal nerve. You feel that all right?
Yes.
Same both sides?
Yes.
Okay, and pull your toes upwards. Obviously, someone with a drop foot, we need to check their peroneal nerves working. And then the sensation on the sole of the foot, you've got the medial and lateral plantar nerves. So, sensation okay?
Yes.
And on the lateral border, the sensation okay? Okay. And again, plantar flexion of the toe. So bend, curl your toes downwards, push down, that's it. And that one, good. Okay. Patients with foot pain could well have a spinal pathology, so it'd be worth perhaps doing a quick straight leg raise. You could lay the patient down to make sure there's no obvious root entrapment. And any pathology that you've identified in the knee, you should probably also go on and examine the knee, because the knee has a huge impact on the foot. So let's just clarify a few things with the foot and ankle examination. A few things about inspection. If you just turn around and face away, John. So we've made the point about inspecting from behind. I mentioned about calf wasting. If you see calf wasting, there's a few things that you really should spring to mind. You're thinking particularly of neurological conditions, so previous polio, previous stroke, something like that, or previous history of club foot. So calf wasting puts those things at the top of your list. I mentioned previously the too many toes sign, and what that is that we're looking for how many toes are visible on the lateral side as you stand behind the patient. And if there are too many toes visible, so if you just externally rotate this at one foot rather than the other, that's it. That's to illustrate the point. You can see too many toes on the one side, and that strongly suggests that you've got tibialis posterior dysfunction. Okay, if you turn around now and face the camera, John. Just something else to mention about the gait. The various gaits we're looking for, particularly with the foot and ankle, we're thinking of something like a high stepping gait. So can you demonstrate a high stepping gait, John, or a drop foot gait? And the key feature of this is that patients lost active dorsiflexion of the ankle, and so they tend to, instead of having a heel strike, they land with their forefoot. Another thing in gait with the foot and ankle you should look for is the foot progression angle. So as the person walks to and from the examiner, you actually want to see what angle the foot makes with the midline So the feet should be essentially about 10 degrees of external rotation. And so if the patient's walking with significant in-toeing, particularly if it's asymmetrical, then you've got to look for a cause of that. So you're looking further up for tibial torsional deformities or femoral deformities. You also get abnormal gaits in various other neurological conditions. Stroke patients can do a sort of circumducting type gait, and that can have quite a negative impact on the foot and ankle. So just a few comments now about patients who've got flat feet and patients who've got pes cavus. In somebody with a flat foot, more often than not, it's a flexible flat foot. So in other words, they have a flat foot when they're standing, but when their weight is taken off or when you test certain muscle groups, then the arch will restore. So if you felt if somebody has a flat foot, you might find that when they're actually sitting on the couch, that their arch is restored. So that's one sign of a flexible flat foot. Another sign, when you get them onto tiptoes, their medial arch is reformed. Again, that suggests it's a flexible flat foot. And a test you can specifically do is the Jack's test, or the Jack's toe raise test, where you very simply you watch the medial border, the medial arch, and as you passively dorsiflex the big toe, you'll see that the medial arch increases, and that's normal. And so if somebody has a flat foot, very simple test, obviously providing they've not got pain from this joint, is to do this, and if that arch restores, then that's very suggestive that it's a flexible problem. The opposite deformity is pes cavus. Now, pes cavus simply means a high arch, so if you can easily get one or certainly two fingers between the floor and the medial arch, then that suggests a pes cavus. Pes cavus has got to make you think of a neuromuscular problem, and so you've got to be very quick to examine the spine. You want to go through their past medical history if there's been any history of spinal injury or strokes or anything like that, and look for associated deformities. Specifically, you want to look at the long flexors to the toes, so if they've got claw toes, and are those deformities correctable. Quite often as well, when you examine them from the back, you'll see a varus deformity of the heel, which again is a sign of a neuromuscular problem. So just a few comments about patients who complain of pain in their foot. Very useful to be able to examine the foot for specific areas of tenderness. So if patients complain of pain in the forefoot, what you really need to do with your examination is clarify which part is the pathological area. So a good screening test is simply to squeeze across the metatarsal phalangeal joints, and that's a good way of quickly looking at the joints between the metatarsal heads and looking for a sign of itis that you might see in rheumatoid arthritis. If someone's got an interdigital neuroma or a Morton's neuroma, then you can specifically look for tenderness between the metatarsal heads, so between usually the second and third, or the third and fourth, and that might be painful. So you're looking at the patient's face, and you can perform a Mulder's click test. So as you palpate, you then squeeze the metatarsal heads together, and you may feel a click in a normal person, but if they have a painful click which reproduces their symptoms, then that's a positive Mulder's click test for a Morton's neuroma. You then want to palpate individual joints. So is the pain coming from the metatarsal phalangeal joints? If they've got any callosities, you want to palpate a callosity, and a callus will be painful to direct palpation. If it's a verruca, they're more likely to have pain when you squeeze it from side to side. That's exquisitely painful in a verruca, and you'll see a little punctum in the middle. Some patients have stress fractures of the metatarsal neck, and again, pressing on the second metatarsal head classically will cause pain there. Moving on to the hindfoot, some patients have hindfoot pain, and again, the location of tenderness is very helpful. So we've already mentioned palpating over the tuberosity of the calcaneus, looking for signs of plantar fasciitis. You can have pain where the Achilles tendon inserts posteriorly. Patients can have pain from the subtalar joint, so you're palpating along the subtalar joint. And also if patients have got entrapment of the tibial nerve behind the medial malleolus in the tarsal tunnel, then again have a feel there for tenderness, have a feel for any thickening, and then you can go on and perform extra tests for tarsal tunnel syndrome. Just a few comments now on patients who've got deformities. it's very important to be able to tell whether a deformity is fixed or whether it's mobile. And this particularly applies to hallux valgus. So if you've got a bunion, can you correct the deformity? So obviously John doesn't have a bunion, but essentially you stabilise the first metatarsal bone and then reduce the joint, and you're looking for pain and correctability. Patients who've got abnormal lesser toes, you've got the classic deformities of a mallet toe, hammer toe and a claw toe. So claw toes, they have flexion of both interphalangeal joints and hyperextension of the metatarsophalangeal joints. And again, you want to see, is that correctable? So it's really a case of reducing the metatarsal phalangeal joint and extending the interphalangeal joints. So is the claw toe correctable or not? Hammer toe is where you've got flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint. Again, looking for correctability, looking for any calluses or skin changes over the proximal interphalangeal joint. And then a mallet toe is where you've got flexion of the distal interphalangeal joint. And again, you want to see, is that correctable or not? So that's the key with deformities: areas of tenderness, areas of skin changes and correctability. So we ought to probably test also the ankle ligaments, particularly if any history suggests instability. So the first test we should do is the anterior draw test, which checks the anterior part of the lateral ligament, so the anterior talofibular ligament. And the way to do that is really quite simple, just to stabilise the ankle by grasping firmly just above the malleoli, and then to allow the ankle to fall into a comfortable position of flexion, and then to grasp the heel. And you're simply trying to draw the talus forwards in the hind foot, in the ankle joint. And personally, I find that quite a difficult test to do, but obviously if it's abnormal, then you really can feel a difference, particularly if you compare it to the other side. The next test to do is the talar tilt test, and that is looking for integrity of the lateral ligament, specifically the calcaneofibular ligament. And the way you do that, again, grasp the distal end of the lower leg, and I find if I place my thumb just distal to the lateral malleolus over the calcaneofibular ligament, and then by grasping the heel, keeping an eye on the patient's face, you can then tilt the ankle into varus. And as you do that, you get the impression as to whether there's excessive opening up on the lateral side, and you can actually palpate the calcaneofibular ligament in John as I do that. And you can do that in various positions of flexion, and that will indicate more whether one aspect of the ligament is intact or not. When you're examining somebody from behind, we've already mentioned that the hind foot should be in a valgus alignment, but on some occasions you'll find that patients have a varus alignment of their hind foot, so patients with a pes cavus deformity, for example. And it's important when planning surgery to know whether that varus reflects a fixed deformity of the hind foot, or if it's not affecting the hind foot and it's more of a forefoot problem. So if they've got a forefoot problem, say their big toe is being pulled downwards, then that will create this varus posture, but the problem is in the forefoot. Whereas if they've got a problem with their subtalar joint, then that can be creating the varus deformity. So from a surgeon's point of view, you need to know, is this purely a forefoot problem or is there also a hind foot problem? And the test to distinguish that is the Coleman block test. So I'll show you how to do that. So if you just turn and face away from us, John, and we'll do it on this leg. So if you just stand on this, so use a block, sort of 2 to 3 inches, a BNF will do just fine. And so you stand him on a block, and you'll note the position of his heel. Now, obviously with John, it's in a valgus posture. But if a patient's got varus posture, then you want to just make a mental note of that. Then what you do is you adjust the block so that his first metatarsal head is no longer supported, but the rest of his foot is, and then re-examine. And if by adjusting the block so that his first metatarsal head has fallen down, if that has resulted in less varus or a return of valgus, then that tells you that the hind foot is flexible. So the problem is purely a forefoot problem. If, however, by moving the block, even though you're now allowing the first metatarsal head to fall, if the hindfoot has stayed in varus, then that tells you that there's a hindfoot problem and you need to address that as well. A few points on examination of the various tendons around the ankle and foot. The most common one we really need to assess in clinical practice is the Achilles tendon. And the test specifically designed for that is so-called Simmons test or the calf squeeze test. And to do that, I find it easiest if the patient kneels on a chair. So if you could just do that for us, John. Okay. So firstly, we can inspect both Achilles tendons here. We can look for symmetry, we can look for swelling, any thickening, and sometimes you can even see a gap between in the tendon. Further, you can go and clarify areas of pathology by palpation and noted any tenderness. The next thing you should look at is to see whether the tendon is in one piece or not, whether there's been a rupture. First sign that there's been a rupture may be that the posture of the feet is actually slightly different. So if, for example, there was a rupture here, then there's less resting flexion tone. So the foot will tend to sit more in that posture. So they won't sit in a symmetrical way. You'll find that because there is no pull now, functionally, of the ankle flexors, that the foot and the ankle rests in that position. Okay, so if you just relax. To formally test the integrity of the Achilles, then we do the calf squeeze test. And obviously John has an integral, an intact Achilles, but the test is performed by squeezing the calf and watching for movement of the foot. And effectively you're simulating a calf contraction, and so the foot moves like that. And in someone with a ruptured Achilles, then the foot will barely move, and obviously you need to test with the other side. It can be quite confusing as to what constitutes a positive test. So some people will say calf squeeze test is positive, and I think that's unclear as to whether positive means the foot does move or the foot doesn't move. So I would say that the calf squeeze test confirms that the Achilles is intact, or confirms that the Achilles is ruptured. And then obviously then you can go on and formally assess the power in the Achilles. So can you push me away, sir? Okay, and that's simply testing the integrity of the Achilles tendon. So can you just sit down now, John? So that's the Achilles. There's obviously lots of other tendons around the foot and ankle, and you should assess each of those as indicated. But just to give you some basic pointers, I think what you should do is get the patient to do the movement themselves first. So you're testing that they've got power against gravity. So you're testing MRC grades sort of 1 and 2 and 3. And then you then want to go on and then resist the movement that they have made. So you can then assess whether they're MRC grade 4 or 5. So for tibialis posterior, what you want the patient to do is to put the foot into position of inversion, essentially. So what I do is I ask them to bring your big toe to touch my finger. So he's there inverting his foot, and he's done that actively, and I can confirm that the tibialis posterior is intact as I palpate, and then I resist. So hold that position, and I can feel tibialis posterior contracting, and I can even see it in John. So that's tibialis posterior. For the peroneal tendons, same thing. So can you touch my finger over there? So he brings his foot into eversion and hold that position. I can palpate, and I'm sure you can see his peroneal tendons, and I resist that movement. Okay, that's fine. Testing tibialis anterior. Can you bring your toe up to touch me? And you can see his tibialis anterior there. And again, hold that position. And that's the tibialis anterior. And same applies for the big toe, so EHL, and then for toe flexion, so the FHL. Can you curl your toes down, hold it there. So same principles apply to all the tendons. So I would say get the patient to make the movement first, and then palpate the tendon as you resist it. The only other thing to say about tendons is sometimes you can get snapping tendons, particularly around the peronei, and so what you do in that situation is you get the patient to go into eversion against resistance, and as they do that you feel over their peroneal tendons for a little click, and obviously the patient may report a painful snap as they do that. So that's resisted eversion for peroneal tendon subluxation. I think that just about covers everything we need to say for the foot and ankle. Perhaps one final thing to mention is when planning operations on these patients, it's extremely important that you're confident that the blood supply to the area is good. So apart from checking the pulses, if there's any doubt, you need to go on and do your ankle breaker pressure index. You need to do Buerger's angle, and maybe even ask for a vascular opinion before starting to operate on these patients.